Hi everyone. Good evening. How are you guys? I hope you guys are doing good. Yes, great, great, great. Thank you guys. Okay, so let's start and let's start the module of emergency medicine. And that is a very common topic. So I thought, okay, I'll invite everyone to join this, whoever is interested in 4 or 5 groups I've shared. So I'm seeing a nice audience here, guys. Thank you very much for joining. And okay, so I'll come to today's point. Today's point, we are going to talk about medication errors. Okay, that is one of the most important topic for all pharmacy students, I believe. Okay, all pharmacy students, because medication errors happens in the hospitals, in any prescription, at your home, at your, with your uh, parents, your grandparents, your relatives, anywhere. I mean, it can happen. Okay, so it is generalized topic, and it is one of the wonderful topic which we all should, discuss, and we all should, learn about it. Right. This is one of the a very interesting topic as well. So, guys, let's discuss about not able to hear. Is it, guys? Am I audible? Can you please confirm if I'm audible or not? Okay.
Yes, sir.
Okay, great. Thank you. I think then, Sneha, you should check your network, please. Okay, let me share the screen and then we can discuss about the medication errors. So, guys, what do you think? What is medication errors? Let's make it interactive. Today's session will be around 60 to 90 minutes, and we will be, talking about all types of medication errors and all. And I have a fantastic case discussion what I'm going to discuss with you, and I'm, making it a very interactive. I'll ask you a lot of questions. So, guys, tell me, what is medication errors according to you, and what do you think medication errors can do, and what they can do? I mean, whatever you think about the medication errors, please tell me what is medication errors according to you. Yes, guys, make it interactive. You can speak, you can write, you can write in the chat box. Anything is fine for me if you can tell me about medication errors. And I'm very sure, guys, I will take you through the types of medication errors, the in-depth knowledge of medication errors today. In-depth knowledge of medication errors. Okay, you might have not even heard of before, some types of medication errors, what I will take you through today. Okay, with the examples and with the everything. When the medication rights are violated, then it is called as medication error. Okay, ma'am. Okay, anyone else who wants to put the light on this? Yes, guys. Anyone else who wants to put the light on medication errors? Wrong prescription of drug, wrong prescribing of drug. Okay, anyone else? Okay, so let's start. So today we are going to learn about important facts about medication errors, classification of the medication errors. There are three types of major classifications. One is psychological approach, one is prescription-based approach, one is NCC MERP classification. So first, guys, right, my question to all of you here is, how many of you are aware of NCC MERP types of, I mean, the NCC MERP classification of medication errors? How many of you are aware of? Please write yes if you are aware of NCC MERP classification of medication errors. Are you aware of NCC MERP? Yes. Prescription based approach, I know many of you would be. Okay. How many of you know about the psychological approach of medication errors? Anyone? No. Okay. So let's go through the things and let's understand the things. So, guys, there are many types, and I request everyone here to put off their mics. Okay, no mics must be on in between, otherwise I have to keep it off, frankly, because no disturbance is very important in the session, right? So let's see. First of all, let me tell you a little uh, statistics behind it. You know, the people okay, my pen is not working, is it? Wait, why my pen is not working? Oh, one sec, guys. I'm so sorry, my pen is not working, I believe. Hmm. One sec, guys. I'll just set my pen. It's not working. I don't know why. Okay. Okay. Now it's working, I believe. Okay. Right corner. Yeah, yeah. No, no. I was trying with the right corner only, but yeah, it was not. Okay. No worries, guys. Again, let's start. So today we are going to talk about these things and we are going to learn about these all things. So let's start with the medication facts. So before that, I let me tell you some statistics. You know what happens if somebody is taking more than 5 drugs? How many chances are there for drug interaction? Drug interaction is another type of medication error. Okay, guys, everything is mistake in the prescription. Everything is a mistake, and that is called error. Whether it is a drug interaction, whether it is adverse effect, whether it is adverse event, whatever it is, that is mistake, and that comes under the medication errors. Okay, at any point of time, any kind of mistake in the prescription is called as medication errors. So if the person is taking more than 5 drugs, there are 80% chances of drug interactions. If somebody is taking more than 7 drugs, there are 100% chances of drug interactions. You know that? Did you know that? There are papers on that. Like at what cap, you know, there are the drug interaction starts. So many people, you won't believe that 29% of people, they take more than 10 drugs in a day. This is about USA. India doesn't have count. Okay, India, we don't do such studies in India, right? We don't do such studies in India because we have a lot of wrong stuffs happening in India about antimicrobial stewardship, about wrong prescriptions, about wrong use of the antibiotics and a lot of things, right? So we don't do such studies, and these such studies are not encouraged in India. These studies are from Europe and the western part, and they say that 29% of the total population uses more than 10 drugs in a day, and around 35% of the elderly people, they use 15 drugs a day. 15 drugs a day, and their expenses are around 20% of healthcare expenses goes in medication related problems, complications, and deaths compensations. You know that 20%. So that's why medication errors are important to understand. That's why medication errors are important to understand, right? So to understand the medication errors and to identify preventive strategies, we need to classify them. So we can tackle them one by one, we can tackle them easily, and we can describe them. See, first we are talking about medication errors. And you might not be knowing there is something called medication harm. Harm. Okay, harm is also there. So we'll be discussing today all the parts of medication errors and associated terms, right? So medication error is a failure in the treatment process that lead to or has the potential to lead to harm the patient. Harm, harm is the term here, which is a direct injury, indirect, emotional. I mean, multiple types of injuries are involved in the harm that we are going to discuss in the uh, next slides. Okay, so any kind of failure in the treatment process that leads or has the potential to lead to
What
harm
you
the
say?
patient is called as
Okay. Take the two.
medication errors. Okay, has it's called as medication errors. Okay, guys, so that is called as medication errors. So this is a prescribing fault. That is I mean, prescribing fault means it could be at any level. It could be at any level, and prescribing fault could be could start with the decision making. The decision making can influenced by multiple factors. the decision making of the prescriber, of the whoever is dictating, or whoever is writing, whoever is mentioning, whoever is preparing the chart. It can happen at any level, but with just one decision making. And decision makings can be influenced by multiple factors. Okay, medication errors can be classified in invoking psychological theory. Invoking psychological theory means what? Invoking psychological theory means there are some intentional and some non-intentional mistakes. Okay, some rule-based errors, some are following the good rules. Okay, or some are not following the good rules. Okay, but along with that, there are some people who are not following the good rules but following the bad rules. See, there are three things, right? There is one thing, okay, good rule or bad rule, right? So there are people who are not following them or who are following them, but there are some people who are intentionally following the bad rules. Okay, so there are multiple invoked psychological theory where people either are not following the good rules or they are following the bad rules. Okay, and there are some knowledge based mistakes also. I'll give you examples, multiple examples, but let me tell you, like we all know penicillin has the allergies, right? Penicillin induced allergies are there to the people. But what else? Knowing that is just a basic information that penicillin develops the allergy, right? But when a patient comes to you, you're a clinical pharmacist or pharmacist, when the patient comes to you and you have to give the penicillin dose, right? You have to give the penicillin dose. So knowing that penicillin is allergic is just a knowledge. But the specialized, what you makes the specialized is if you know that your patient is allergic to penicillin or not. That makes you specialized. Knowing that penicillin is allergic will not make you specialized. Knowing that every patient of yours, about their conditions, about their allergies, about their future, about their past, about their outcomes, about their medicines throughout, having that knowledge makes you expert, make you specialized. And what makes you expert? There are three things. One is general information, one is specialized, one is expert. What makes you expert? When you know that penicillin is allergic, okay, and you know that your patient is allergic to penicillin. And what makes you expert? Even knowing that, you are doing the tests for that, and you are asking again. Knowing is okay, but asking again and again the patient, what are you doing, how are you feeling that, and if you are allergic to penicillin, or not only penicillin, there are substitutes of penicillin, there are subgroups of sub elements of penicillin, fluoropenicillins and all. Asking that and making 100% sure that you are not giving penicillin to such patients makes you expert, right? So there are invoking psychological theories at any level. You can make mistakes, whether intentional or unintentional. Okay, and that comes under the medication errors. Then knowledge based errors are there. Rule based mistakes, as I told you, some good rules, some bad rules. And then action based flips. You want to write the clonazepam, but you are writing something else. You want to write the Tazel, but you are writing something else, right? So tell me Sartan, right? You have many similar names. So action based slips are there. Okay, action based slips are there. Then memory based lapses. People forget, as I'm talking about the allergies. The pharmacist, being a doctor, being a nurse, you can forget that. It's not important like you remember always everything. You know that your patient is allergic to penicillin, but when the patient comes to you, you forget and you don't ask. That is again a medication error, right? So there are multiple theories behind it. These are just theories. These are just theories behind the medication errors. Okay, these are just theories. So based on the classifications, we can make the preventive strategies. So let's see, let's go for the next slide and let's learn. So there are majorly three types of medication errors and three types of theory for medication errors. First is psychological, then prescription based, then NCC MERP classifications. Let's go one by one. First, medication errors classification based on psychological approach. See, it does not mean that this classification will not come under the prescription based, or this will not come under the NCC MERP. There are different approaches to classify the medication errors. There are different approaches. So here the approach is, what is error according to knowledge based approach? I mean, sorry, psychological based approach. When actions are intended but not performed. When actions are intended but not performed. Right? Actions means the right action. Suppose I want to write Pentocid 40 mg 100 and before food. And this was supposed to write, this was intended, but I'm just writing pen 100. Over. Doctors do that. You must have seen. They don't write the dosage, they don't write the frequency, they don't write the dose unit, they don't write the instructions properly. So that means when actions are intended to do but not performed in the right way. Okay, there are two types of errors. Psychological approach we talk about. One is mistakes, one is skill based errors, slips and lapses. You have the skills but you do the mistakes, maybe unintended. Here we can talk about unintended, so we can see unintended and intended kind of things. So one is mistakes, errors in the planning, and skill based are errors in the execution. Okay, mistakes are errors in the planning part, and skill based errors are errors in the execution. Execution means when somebody is writing, okay, and he writes something else. He wanted to write something else and he writes something else, maybe because of the disturbance, because of the light, because of the pen, because of anything it could be, right? Then memory lapses, people forget. Then maybe technical error. You are typing nowadays, there are typings, medication type, typists are there. You are telling something else, he's writing something else, or she's writing something else, and it goes to the pharmacist is prescribing something else. I mean, he's dispensing something else, right? Maybe the language is not understandable properly. So those are technical errors. Okay. Skill based errors means what happens in the execution. Execution means either in the prescribing, or in the dispensing, or maybe in administrating, or maybe in dictating, or maybe when you are writing exactly, or whatever. These are execution based errors. Okay, what are mistakes exactly in planning part? Like knowledge based errors, rule based errors. See, I'll not go to this, but some hospital, not only some hospitals, all corporate hospitals usually, if there are, see, there are, if I tell you, tazobactam, and there is a combination of antibiotics, I'll not, tell you the complete stories, but there are the antibiotics injections. Suppose, the high end antibiotic, uh, like gentamicin and all, or there are the sulbactam, or tazobactam and all. These injections are given for the sepsis, right? But what usually happens is there are 10 to 15 good brands and bad brands. 10 to 15 brands are there for the injection. You won't believe that for tazobactam, one injection cost around, it costs from, I'll tell you, it costs from 150 rs to 2500 rs. You won't believe how much is this variety. How much is this variety? How this variety is? See, they are using the same component, they are using the same percentage. It is, they are using the same element, they are using the same chemical entity, they are using the same drug, but still the cost of the injection vary from 150 rupees to 2500 rupees. Why it is? See, maybe your 500 rupees injection from Cipla or Cadila is a perfect one, but still, if you go to the corporate hospital, you will see that same injection they are purchasing in 2000 rupees when it comes to your bill, right? What exactly is there? The injection cost is actually 200 rupees, but the 1800 goes as a commission to the hospital, right? That is rule based error. That is rule based error. They are not practicing the good rules, or they are practicing the bad rules. Either they are not practicing the good rules, or they are practicing the bad rules. Understand? These are psychological things. Psychological means maybe uh, to earn the money, right? Or forgetfulness, maybe in the technical errors. But when we talks about errors in planning, those are mostly intended. Those are mostly intended. And when we talk about skill-based error, those are mostly non-intended. You understand that? Mostly intended or not intended, non-intended. Right. So these are psychological approaches of the people. They know everything, but still the mistake is happening or they are doing the mistake. Mistake is happening or they are doing the mistake. Yes, monopoly could be. Yes, absolutely. That monopoly could be. Or when you go to the hospital, you cannot, do anything. You literally cannot do anything. Sometimes it is up to them. And literally, let me tell you, even in the 2000 rupees injection, there is only water. There is no drug at all. There is no drug at all. You won't see the drug at all in that. Right. So that is intended just misleading or misapplying the good rules. Okay. Now, examples, let me tell you, knowledge-based, rule-based, and action-based, and memory-based errors. Let me tell you the examples. Knowledge-based error, I even given you, like, can be related to any type of knowledge, whether it is general, specific, or expertise. See, general knowledge is then you know that penicillin can cause allergic reactions. Knowing that your patient is allergic to penicillin is specific knowledge. Knowing that co-fluampicil containing penicillin is expert knowledge. Okay, ignorance of these any fact could be knowledge-based error. Okay, so as I was telling you, what makes you special, what makes you specialized, what makes you expert. See, knowing that penicillins are allergic is general knowledge. Students will know, faculties will know, academicians will know, doctor will know, technician will know, even the nurse who is giving the injections will know, right? Everyone will know, pharmacist will know. But knowing specific about the patient makes you specialized, and knowing that some penicillins are also could be allergic, that is the expert knowledge. And if you are ignoring any of them, could lead to knowledge based errors. Rule based errors, the misapplication of a good rule or the failure to apply a good rule, and application of a bad rule. As I told you, the example of the hospitals, doctors, they do. I mean, see, not blaming anyone specific, but it is happening. It happens, right? And action-based errors. The performance of an action that was not what was intended. Yeah, so it could be because of slip of the pen when a doctor intend to write diltiazem but writes diazepam. Example, when the doctor wants to write diltiazem, but he's practicing diazepam more, so he will be like, okay, I'm writing diltiazem, but he write, okay, and the pharmacist dispensing diazepam. That is again the error, right? Memory-based error, when something is forgotten. You know that penicillin is allergic, but you forgot that your patient is allergic to penicillin. That is memory lapse. That is memory based errors. Okay, but all are medication errors. All are medication errors, right? Now, prescription based errors. So prescription based errors are three types again. One, it could happen before prescription. It can happen at the time of prescription, and it can happen after the prescription. So guys, give me one examples of before prescription error, at the time of prescription, and after prescription errors. Yes, guys. I'm waiting for your answers. Kindly give me the answers, which is like before prescription, what type of errors you can see before prescription, and what type of prescription, I mean, during the prescription or after the prescription. Give me one examples from your side. You are from pharma. You all are from pharma background. You are all are either D farm, B farm, or farm D. Give me the examples. Before you will be reading in your hospital pharmacy. You will be reading those in your community pharmacy. You will be reading those in your pharmacy practice. Any drug allergy before prescription. Okay. Medication error. Drug allergies before prescription. Okay. Wrong patient. Oh yo, it's a big deal. Wrong patient is a big deal. Okay, you have not reached here, guys. Okay, leave it. At the time of prescription, please. At the time of prescription, can anyone tell me what are the prescription errors? I mean, prescription errors at the time of writing the prescription. Insufficient patient past. Okay, wrong diagnosis. Insufficient patient past medication history. Okay, that's patient related. Wrong medication abbreviation of the drug. Okay, okay. Dose without indication. Okay. At the time of prescription, like diltiazem as diazepam. Okay, writing wrong prescription frequency. Okay, got it. After prescription, anyone after prescription? Now, after prescription, this is the time to understand after prescription errors. Dispensing, perfectly fine. Dispensing, discharge medicine, okay. Dispensing errors, administration errors, dispensing errors, administration errors. Those could be after the prescription. So, guys, you did not reach exactly about before the prescription errors. Let me tell you. Before the prescription errors could be hospital errors, I mean, hospital related errors, manufacturing errors, packaging errors. You must have seen there are batch number different, there are printing different, expiry date different, I mean expiry date mistakes. Okay, and some batches comes out like half information is printed, half information is just printed, half information. Packaging is wrong. Okay, and they did not follow the cold chain. Okay, did not follow the cold chain if they are sending the injections which are needed, like COVID vaccines or anything. They did not follow the cold chain. Okay, or the drug was in sunlight, drug was not refrigerated, or insulin was kept in the heat. Okay, hot environment. So these could be the packaging errors or manufacturing errors. Manufacturing errors means they did not follow the SOPs, they did not follow the GMPs, they did not follow the GCPs. Manufacturing errors. Okay, big level, guys. Don't think about the small level. You don't know about the patient history and all. These are definitely, these are the I mean before prescription errors, but I can understand. But these are actually during the prescription errors what you are talking about. Before prescription errors means packaging errors, manufacturing errors could be there. Okay, doctor has written. See why it is error and how it is error. Doctor has written diltiazem. I'm talking about diltiazem only. Diltiazem. But when you look at the package, packaging is half. Packaging is broken, or the content inside the tablet is stolen, or tablet is busted out, or the expiry date is missed, or the batch number is missed, right? Or batch number is misplaced, or the drug name is not complete on that. Packaging problems, manufacturing problems could happen before the prescription itself. And hospital policies, as I told you, hospital policies, how it involved in the hospital, I mean, the prescription errors. You know that there is policy making in the hospitals. Pharmacy Therapeutic Committee, Pharmaceutics Therapeutic Committee, PTC. You know about PTC? How many of you know about PTC? How many of you know about PTC, guys? Right? Raise your hand here. PTC. So sorry. Yes, PTC. How many of you know about PTC? Guys, tell me. Okay, PTC is a committee, Pharmaceutical Therapeutic Committee. So they are the key in the hospital to decide what medication will be used, what medication will be purchased, what medication will be used, and what medication will be purchased. Mansi, I think, is raising hand. I'll ask you later. No worries, that you can write if you want. Okay, you want to speak, guys? Wait for a minute. Let me unmute you. Someone was speaking in between so far. Yes, now you can speak. Okay, so pharmacy therapeutic committee is something where they decide what drug will be used, what drug will be involved in the PTC and in the drug manual for next 6 months or next 1 year. Okay, and what drug will be purchased, what drug is benefited, what drug is new, what drug is most prescribed in the hospital. They look into all the statistics of drug uses and cost effectiveness to the hospital and profits to the hospital. Okay, and then they decide what drug will be used and what drug will not be used. That's where the commission purpose comes. That's where the commission comes. Okay, that's where the commission comes. Formulary, yes, we are talking about the drug list formulary. Okay, hospital formulary. So PTC decides the hospital formulary. Okay, so these all are before prescription. Doctors even are not aware. Pharmacist who is involved in the Dispensing is not aware. Nurses who are giving the drug are not aware of that. During the prescription, yes, transcription errors, typing errors, error related to the environmental factors. What are environmental factors? Suppose I'm talking about my hospital. There are 6 lakhs patients per year. There's a very heavy footfall of the patient. So what is environmental related errors? Low dim light. Either there is low or dim light in the cabin. Okay. Fan is not working. People are shouting. Okay. And there is mismanagement. There is no good management of the people. So these all, influence the prescription ultimately. How? Suppose the doctor is seeing the patient and pharmacist is writing, or someone, his assistant is writing, or then what he's dictating, because of the because of the crowd voice, he cannot listen properly. He's writing something else, he's telling something else, doctor is telling something else, and the writer transcriptor is writing something else. Maybe pen is not working. By the time he's getting the new pen, he told something else and he wrote something else. There is a dim light or low light. They don't know how to write properly. They are not exactly seeing the prescription. They are not exactly seeing the diagnosis. They are not exactly seeing the file. So there are multiple environmental related factors. Drug related confusions, sound same. The drug names sound same. Drug names look like drugs, sounds like drugs. You know that there are drugs which are sounds alike. Sounds alike means they are sounding similar. Then there are looks alike drug, which are looking similarly, and there are many tablets which look similarly yellow. So if you talk about my mom, how my mom recognizes the tablets, she takes, okay, yellow tablet I have to take in the morning, red tablet I have in the evening, and white tablet in the afternoon. That's how she recognizes the tablets. Yeah, so lassa drugs looks like and sounds like, right? So these are the major reasons for the drug related confusions. These are the major problems related to drug related confusions. Okay, now I'll come to after prescription drugs. Administration comes after prescription. See, doctor has told right drug, but pharmacist dispensed something else, wrong drug. Okay, pharmacist dispensed wrong drug, and it comes to the nurse. It comes to the nurse or the patient. They don't match it with the prescription at all. They don't match it with the prescription. Whatever has come, they will just getting and the patient, giving to the patient. So that is coming under the someone's mic is on, guys. You're not speaking, please put off your mics. Okay, I think nobody is speaking. Okay, so that is administration error. They don't look. Patient even don't know. Patient parties don't know. The attendees don't know, right? What is dispensed and what they have to take, what patient has to take. They don't know. Monitoring errors. Monitoring errors means what? Like when to give, how to monitor, what to monitor. If we are giving, diuretics, we have to monitor potassium. They don't monitor properly. Nurses don't monitor properly. Sometimes pharmacists don't look properly. Clinical pharmacist is not looking into prescriptions properly. They are not auditing the prescriptions properly. So these are monitoring errors, dispensing errors from the pharmacist side, and non-adherence and education from the patient side. These are patient related problem. This is pharmacist related problem. This is nursing related problem, right? So these all problems happening at any level, whether they are pharmacy level, pharmacist level, nurses level, doctors level, prescriber level, or the writer level, or at the patient caregiver level. But these all are mistakes, whether they are before prescription, after prescription, or during the prescription. These are the major mistakes what the patient feels or what the patient has to suffer later, right? They have to suffer later for these. Now I'll come to one of the most important classification, which is given by National Coordinating Committee. National Coordinating Committee for Medication Error Reporting and Prevention. That is called as NCCMERP. NCCMERP. They have given the categories. They have classified the drug errors or medication errors from A to I. Okay, A to I. A, B, C, D, E, F, G, H, I. Right. So what is A? And I mean, see, first of all, first is category. Let's understand this table first. then if the error occurred or not. But error occurring or not is not a problem. If it is reaching the patient and it is causing the harm, that is important. See, there will be packaging errors, but some drug inspector came and they caught that, okay, this packaging is wrong. Okay, this drug has not followed the GCP rules or GMP rules. So they will, retain that medications from the market only. That will not reach the patient. That is important. If the medication error is reaching the patient and causing any kind of harm to the patient. Or so the thing is, first is medication error A. That is one of the most potential error, but not reaching the patient. Here it comes like the manufacturing errors, okay, packaging errors. Errors are major. Errors are major potential to harm the patient, but they are not reaching the patient. A. B is also error is occurring, but not reaching the patient. So when these are not reaching the patient means there is no chances to harm the patient, and then there is no necessary measures are required from the doctor side or hospital side. There is no need of any kind of measures, either monitoring or hospitalization or vital support, or any kind of treatment is not required. So A and B are the types of error which are potential, which occurs but do not reach the patient and not associated with any harm. Now there are some mild errors which reach, the errors which are reaching the patient but not causing any specific harm, like C and D. C and D are reaching the patient but not causing any kind of harm, and so not required anything. Only, I'm so sorry, only monitoring is required, or monitoring is also not required in case of C and D. Okay, in case of C, there is no monitoring required, no action required, but in case of D, only monitoring is required. Okay, then E. E is happening and reaching the patient, but after reaching the patient, it is causing just the temporary harm. So some medication intervention, like, okay, patient got the tablet and patient got the vomiting, and he was given, some tramadol or something else. Okay, or maybe some other domperidone for the vomiting or nausea. That's it, temporary harm. Okay, again, F is similar. It is the error reaching the patient and causing the harm, but harm is a little moderate. Harm is kind of moderate, needs hospitalization, and if the patient is hospitalized already, it may prolong the hospital stay. It may prolong the hospital stay. So what kind of errors could happen in the hospital which are temporary, not causing any permanent harm, but which can increase the errors? The error, I'll give you the best example. Suppose the patient is asthmatic and hypertensive. Okay, patient is asthmatic and hypertensive, and he went to the cardiologist. He did not ask if the patient is asthmatic or not, or he forgot and he prescribed the beta blockers. The same thing happened with my mom once, literally, some 3 years back. She is asthmatic and hypertensive. She was prescribed with metoprolol. Okay, she was prescribed with metoprolol. She took the metoprolol and her asthma accelerated to the high level, intense level. We had to hospitalize her. We had to hospitalize at that time. So that is the error which happens and which needs a little more than the medical intervention, maybe the hospitalization. So that is the medication error. Then there are some very, very high intense errors which causes the severe harm, like error from G to I. Okay, GHI category errors are very, very intense. So there is a permanent harm. Okay, in G, permanent harm means like, maybe the gangrene or the amputation, or maybe something else, permanent harm. Okay, and H is causing the risk of death. Okay, risk of death. So in that case, vital supports are required. Patient will not die, but there is a high risk of death due to the medication error, due to the medication related problem. And then the last is I, where the error occurs, reach the patient, and the patient dies because of the error. Okay, so this is the error chart from National Coordinating Committee for Medication Error Reporting and Prevention, NCC MERP classification. Okay, and when we, people there are many of my PharmD students and other students, M-Pharm students. They are doing the projects on NCC-MERP. They are finding the medication errors based on NCC-MERP. They are classifying the errors in heart failure. They are classifying the errors in rheumatology, psychology, and other diseases. So this is one of the good topic for the project also. If you are working in the hospital, you want to do something, you want to classify the medication errors, you want to alleviate the medication errors from the hospital, from your department where you're working, you can use NCC MERP classification for the medication errors. Okay, guys. So this is one of the important classification for that. And this chart reflects it very, very importantly, very, very nicely. So AB to I, A to I, see, A is the circumstances or events that have the capacity to cause error, but not reaching the patient. Okay, not reaching the patient. These are no errors happen during the prescription or not reaching the patient exactly. B is error but no harm. C is error but no harm. D is error but no harm. You can classify with the colors. Error, no harm. Error, harm. Yellow, error, harm. And green is error and death. Okay, green is error and death. B is like an error occurred, but the error did not reach the patient. Error occurred that reached the patient but did not cause any potential harm. Error occurred that reached the patient and required monitoring to confirm it. Okay, error occurred may have contributed to resulted in the temporary harm and patient needs the hospitalization or prolonged hospitalization. Okay, and error G and I like permanent harm, permanent disability, and intervention which needs to sustain the life, and death, right? Death. So these are the things we must know about the error classification. Okay, error classification. I have given you multiple examples in that area, and you know that you will give me the examples, and I will give you the entire case to discuss with me. Okay, then harm. Okay, I'll come to the harm. Right? What is harm exactly? See, all the errors, all the errors which reaches the patient, all the errors which reach the patient causes harm, right? Without harm, there is no error. Error is the process, harm is the result. Okay, guys, remember this. Error is the process. Okay, and harm is the result. Remember this. So error, if error is happening and reaching the patient, it will cause harm, whether that is physical, that is emotional, psychological function deterioration. It may happen because of multiple drugs, right? Emotional damage can happen because of the drugs, and structure of the body or the pain can get affected. Injury resulting therefore like gangrene, and you have to amputate, or there are multiple things which happens due to drugs. So there are impairment of either your physical or emotional or psychological functions or structure of the body, or injury resulting therefore. Okay, so there could be multiple types of harms. Okay, this is also given by NCC MERP, National Coordinating Committee for Medication Errors Reporting and Prevention. So there are two types of harms, guys. Okay, there are two types of harm. One is potential to. One is potential, one is actual. Can someone tell me what is potential? What is the difference between potential and actual? Yes. Yes, terminology for harm is different. Like some say it is problematic, some say likely harm, serious harm, patient outcome is harm, related harm, potential consequences, potential severity of the patient, clinical significant, sequel, potential risk, high risk. Risk is also harm, assumed consequences, predicted outcomes. These are just terminology. Okay, but there are majorly two types of harm. One is potential harm, one is actual harm. So can someone from my audience tell me what exactly is the difference between potential and actual harm? Yes, guys. What exactly is the difference between potential harm and actual harm? It's a very one word answer. Without looking into the Google, tell me. Without looking into the Google, tell me, guys. Yes, what is potential harm? What is actual harm? Array, actual harm means already happened. It was supposed to happen. It was supposed to happen. It could cause the harm. Could. Okay. Could is for potential, and done. It has done. It is done. Okay. Potential harm means this drug could cause the potential harm. Could do. Okay. Potential means ability to gram. Yes, absolutely. Potential means ability. It could do. Okay. It was supposed to happen. Okay. It was supposed to happen. It could have been done. And it is done. There is a difference. There's a difference between it could have been done and it had been done. Okay, it has been done. So there is a difference. It is done or could have done, right? So let's see. What is the difference? There is nothing exactly. So I mean, difference has come from HAMAC, harm associated with medication error classification, HAMAC. Okay, so it was proposed by Peter J. Gates from the Center of Health Systems and Safety Research, Australian Institute of Health Innovation, Mercury University, Sydney, New South Wales, Australia. Okay, so this was from HAMAC. Now there are like HAMAC ka classification for potential risk, potential harm, and actual harms. So there is no difference between potential harm and actual harm difference. I mean classification. All are no harm, minor, moderate, severe. Okay, all are no harm. If you see here also no harm, minor, moderate, severe, serious. But only one thing is there is no potential to the potential. There is no potential for patient harm. There was potential for minor, non-life threatening, temporary harm that may or may not require efforts to assess for a change in the patient's condition, such as monitoring. I mean, minor harm means there was a potential for minor harm. Was potential. That is the term which will be removed when we are talking about actual harm. Okay, so definition is exact same for potential and actual. Okay, so potential harm means there was potential for major non-life threatening temporary harm. Moderate is there was a potential for minor non-life threatening temporary harm that would require such as monitoring and addition of low level changes in patient's level of care, means additional medicines might be needed, and blood tests like for the monitoring are needed. Okay, that is in the moderate. Serious harm is what? Serious harm is, again, it is a potential for major non-life threatening temporary harm or minor permanent harm. Major temporary harm or minor permanent harm that would require a high level of care, such as administration of antidote, and increase the length of care more than 1 day is expected in the serious. Severe is when there was a potential for life threatening or mortal harm or major permanent harm that would require a level of very high level of care, such as administration of antidote, transfer to intensive care. A substantial increase in length of more than 1 day is expected. That was supposed to fall. And when we look at this, same thing, actual harm has happened. There was no actual harm. And minor means there was actual minor. It has happened. There was. Okay. There was. It has already happened. Is needed. Moderate, there was an actual minor non-life threatening temporary harm that did require. It was required and the patient has got minimum a 1 day or less than 1 day hospitalization, of increase in the hospitalization. When serious, same thing, severe, life-threatening or mortal harm or major permanent harm that requires a very high level of care. Okay, so these are the types of harms you must understand. This is the HAMEC classification published in 2019 in Drug Safety by Peter J. Gates. Okay, now I'll come to the case scenario, guys. So before I come to the case scenario, I want all of you to ask the questions. If you have any questions till now, then we can go to the case scenario and I will ask you the questions and you will discuss all the questions and all the case with me. Guys, do you have any questions right now for me? Do you have any questions for me right now, guys? Anyone, right? Raise your hand if you have questions. Okay, so I'll come to the case. Listen, everyone, you all have to participate. I am opening your mics. You can speak now. After this, you can also speak. Okay. See, there is a 63-year-old male. There is a 63-year-old male with BMI of 26.7 presented to the emergency. Emergency people, listen to it carefully and you have to answer. Presented to the emergency with shortness of breath and pain in left arm for past
Start
3 days.
talking shortness of breath.
Shortness of breath in past 3 days. His father expired at the age of 53 by myocardial infarction. Myocardial infarction for the first year, second year people, myocardial infarction is nothing but heart attack. Okay, in no general terms, I'm telling you. Okay, myocardial infarction. Right now, this is the about the patient, and then the patient is also on tablet NVAS 5 mg. He is current smoker and his LDL was 165 mg per DL when he was visiting the patient, visiting the physician 2 months back, which the patient was visiting the physician 2 months back. Now his anti-proBNP, TSH, FBS, and glycated HB. So this is anti-proBNP 1656. This is TSH 2.3. This is fasting blood sugar 267 and HB, glycated HB is 9.8. During the current visit to the hospital, PTCA to LAD and RCA was done on day 2 and started on the following prescription. I'll come to the prescription. First, let me know from your side, what is the diagnosis to this patient? Tell me the full final diagnosis of the patient, guys. Write the final diagnosis of the patient. Yes, everyone. Write the final diagnosis of the patient to me. Here, guys. Please write the final diagnosis. What is the final diagnosis for this patient? Please speak. No problem. Mansi Jain, you're raising hand. Please speak. No worries. You can speak. You can write in the chat box. What is the final diagnosis? And what are the key points from this slide? Yes. What are the key points from this slide, guys? What are the key points you take? Everyone, please speak or please write. MI, hypertension with uncontrolled diabetes. Family history. Okay, wonderful. Family history. Wonderful. Family history of myocardial infarction is there. That is a very important point. Notable point, Cypria. Thank you. This is a family history is very much notable point here. Okay, yes, definitely this patient is myocardial infarction, hypertension with uncontrolled diabetes. Yes, type 2 DM, hypertension, and coronary artery disease. Absolutely. Okay, tell me what is, guys, tell me what is tablet NVAS and what is the indication for NVAS. NVAS is for heart attack, enalapril. Enalapril is for hypertension. Yes, enalapril is for hypertension, but nowadays if the patient is heart attack also, enalapril is the first line therapy. If the patient is hypertensive with heart attack, the myocardial infarction. If the patient is heart failure also, enalapril is the first choice of drug. The ACE inhibitors are the first choice. Okay, so final diagnosis of the patient, you still, you people got almost everything correctly, but you did not get everything in one line. Okay, what is in one line? If I tell you what is the one line final diagnosis for this patient is, so first of all first of all, look at this. PTC to LAD RCA, I'll describe that. First thing is, patient is, you can write ACS, you can write MI, you can write CAD, whatever you want. Patient is patient has myocardial infarction, that is coronary artery disease or acute coronary syndrome right now, because patient is hospitalized. Acute coronary syndrome. Okay. And then the second thing is hypertension. Patient is on enalapril already. Patient's LDL is 165. So what else is there? Hyperlipidemia. Hyperlipidemia. You forgot it. Hyperlipidemia. Someone has written actually hyperlipidemia. Then what else? Then what else, guys? GlyHB 9.8, uncontrolled hyper diabetes, uncontrolled DM. Okay, uncontrolled DM. So here, if you note one more thing, anti-proBNP is 1656. That is the sign of, that is the biomarker for what? Heart failure. Heart failure also has started. Okay, maybe because of myocardial infarction or anything, but heart failure is also there. Anti-proBNP must be less than 150 picogram per ml. Okay, and it is 1656 here. Okay, so this patient has multiple problems: MI, hypertension, hyperlipidemia, diabetes, and heart failure. Now I'll come to the last line. I'll tell you what exactly this is. During the current visit to the hospital, PTCA is nothing but percutaneous transluminal coronary angioplasty. That is the treatment of MI. That is the treatment of heart attack where people are stented. We put the stent at the place of block. We remove the block from the coronary artery and we put the stent, that is medicated stent, that is called as drug eluting stents. DES, drug eluting stents. Okay, so the stents means the mass, metal mass. Okay, stents are made of metal. So usually metal, nowadays biodegradable substances are also there, but metal usually. Okay, so these stents are the metal masses with medication. So these medication are, slow release medications, goes with goes for years. Okay, so these, wherever the block is inside the coronary artery, inside the heart, we remove the block and we put the stent there. Okay, that is called PTC, percutaneous transluminal coronary angioplasty. If it is without stent, then we call it PCI. PCI with or without stent. Okay, if definitely with stent, then percutaneous transluminal coronary angioplasty. Okay. Percutaneous transluminal coronary angioplasty was done to LAD. What is LAD? LAD is the artery, left side artery, left ascending descending artery, left ascending descending artery in the heart. RCA is right coronary artery, right heart in the, right coronary artery in the heart. So suppose, in the heart, like suppose these are the arteries. So this arteries goes right side, this arteries goes left side. Okay, these arteries go left side, and this is the left main. Okay, left main coronary artery, LMCA main, and this is the entire RCA, right coronary artery. And after that there are branches. Okay, after that there are branches. So the again after LMCA, the major artery is called as LAD. Okay, left ascending descending, which is going to the ascending side of the heart. And along with that there are LCX. Okay, left circumference artery is there, and there are many more, D1, D2, diaphragmatic 1, diaphragmatic 2 arteries are there. Okay, so LAD is the right side, left side artery, and RC is the right coronary artery. Okay, where the block was and PTC was done, stent was put in right side and left side. Okay, and started on the following prescription. Now I'll come to the point for all of you. I'm so sorry. Yeah. Okay, yeah. Yes. So this is the prescription, guys. Check it carefully. Check it carefully. Okay. Ecosprin 75 mg 010. What exactly the drug is, guys? Can you please tell me what drug is there inside? What is the content inside the drug? Diabetic cardiomyopathy? No. Aspirin. Cardiovas. What is Cardiovas? Cardiovas. Yes, guys. What is Cardiovas? Carvedilol. Yes, Carvedilol. Carvedilol. What is Axer? 180 mg. Ticagrelor. Okay. What is Thyronorm? Thyroxine. Okay. What is Frusilac DS? What is Frusilac DS? Yes, guys. Do you know what is Frusilac DS? Spironolactone. Only furosemide plus spironolactone. Do you think furosemide and spironolactone? Not at all. This is furosemide double strength. Furosemide DS is furosemide double strength. Okay, not spironolactone. Okay, atorvastatin. Dolo, PCM. Warfarin. Clexane, enoxaparin. Okay. H2 check D. What is H2 check D? H2 check D. Gastric. Yeah, it is for gastric. But what exactly? H2 check. It's a very simple name. Proton pump inhibitor. PPI. This is pantoprazole and domperidone. This is pantoprazole and domperidone. H2 check is pantoprazole and domperidone. Okay. Now, guys, I have questions for all of you. Okay, I have questions for all of you. Can someone tell me? Okay, this is the final diagnosis: myocardial infarction, hypertension, heart failure, hyperlipidemia, diabetes, mellitus. Right now, okay, I'll go one by one. Okay, first of all, tell me the medication errors here. Medication errors one by one. Yes, guys. Okay, ecosprin, I'll tell you, this is perfectly fine. Ecosprin 75 mg is given once a day. Afternoon de do ya morning de do, doesn't matter. Okay, it's okay. What about Cardivas? What about Cardivas? Okay, I'm sorry. What about Cardivas, guys? What about Cardivas? Cardivas is correct or not? Okay, I have to see the. No, no, no. Okay, okay. Let me see. Okay, there are many things. No insulin. Oh, very nice. Regina has point here. There is no medication for diabetes. You understand that? There is no medication for diabetes. The big blunder has happened here. There is a big blunder. There is no medication for diabetes. What is it called exactly, guys? What is it called exactly? Tell me. That is called as what? Indication without drug. Indication without drug. Absolutely. There is an indication, but there is no drug, right? There is no drug. Okay, now I'll come back. Atorvastatin dose and right time. Okay, atorvastatin dose must be what? And timings. Okay, wrong abbreviation. T used for tablets. Okay, I can understand that. Treatment for diabetes not included. Yes. Atorvastatin. Tylenol must be taken before food in the morning. It has written after meal, so it should be taken before food. Tylenol taken in the early morning. Tylenol. Okay, let's go one by one. Let's go one by one. Okay, let's go one by one. I'll see one by one. Okay, so okay, see, Cardivas. Tell about Cardivas. Cardivas is correct. Okay, what about XR 180 mg, guys? No one has told about XR 180. Is it correct or wrong? Wrong or right? XR is right or wrong? XR 90 mg BD, wrong dose. See, a ticagrelor. This is ticagrelor. Ticagrelor. Okay, ticagrelor. So this only comes in 90 mg fixed dose. This is a fixed dose tablet. Okay, this is a fixed dose tablet. So it always come in 90 mg and the daily dose is 180 mg only. And here it has given 180 mg twice daily. 180 mg in the morning, 180 mg in the evening. That is not possible, right? That will lead to what? If we are giving 180 mg twice daily, what will happen, guys? Can someone write? If we are giving 180 mg twice, what will happen? Anyone? Intracranial hemorrhage, ADR. Oh, ADR will happen, but what exactly? Bleeding. Bleeding can happen anyways. Bleeding can come from your gums, your teeth, your intracranial hemorrhage, your gastric hemorrhage, your gastric ulcer. anything can happen. Okay, bleeding is the major problem. Bleeding is the major problem. Bleeding related problems can happen. Hemorrhage can happen if you are taking the high dose of ticagrelor. So ticagrelor dose must be 90 mg 101. What about Thionorom? Yes, it should be before food. It should be before food, right? Before food. Fruits like DS, okay. Zero half zero must be okay. Zero half zero must be okay, right? What about atorvastatin? You are rightly said atorvastatin comes in either 10 mg, 20 mg, 5 mg. Okay, so it would be 20 mg and the dose will be night only. Okay, dose will be in the night. Okay, absolutely. So dose we have corrected 20 mg night. Dolo, why Dolo? Dolo ka problem. What is the problem with Dolo? Dolo strength is missing. Dolo strength is missing. Yes, Thyronorm dose is missing. Thyronorm dose is also wrong. Thyronorm doesn't come in mg at all. Thyronorm comes in mcg, microgram. Whether it is 12.5 microgram, 25 microgram, 50 microgram, 100 microgram, 125 microgram. Okay, mcg, it comes in mcg, and before meal, okay, it comes in mcg, right? So first of all, Dolo. Okay, Dolo is many problems. Dose is missing, strength is missing, okay, and frequency is missing. If it is SOS written, must be written SOS. And it looks like the drug without indication. It looks like the drug without indication here. You know that it looks like the drug without indication. Now, what about the warfarin, guys? That's important. What about warfarin? Is it all correct? Can we give it with grape juice? Grape juice? Okay, Eva is telling warfarin should not be given with grapefruit juice. This is first of all anticoagulant. Okay, this is first of all anticoagulant. This is again the drug without indication. This is again drug without indication. There is no indication. MI is not required. Warfarin is not required at all because we have ticagrelor, we have aspirin here. Okay, this is drug without indication. And with grape juice or not? Just write with grape juice we should give or not. Yes, guys. No. Okay. Anyone else should not give. Okay, Regina is writing no, 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 nay, no. Okay, Parmanand Yadav is writing nay. Oh my God. Should not give. Perfectly fine, guys. But I disagree. Did you read what is exactly it is written? That's why it is called psychiatric approach of medication errors. Did you know what is the difference between grapefruit and grape? Do you know? How many people really, guys, please tell me, how many people really think that grapes are grapefruit? How many people think that grapes are grapefruit? How many people think that grapes are grapefruit? Raise your hands. Raise your hands who understand that grapes are grapefruit. Yes, guys. How many people think that grapes are grapefruit? Grapes are not grapefruit. Grapefruit is a citrus family. Okay. Grapefruit is the citrus family. Today you go and search in the Google what is grapefruit. Okay. Grapefruit is a citrus family and there is no harm giving warfarin if it is given. Okay. If it is given, I'm telling. If it is given, we can give with grape juice, but not grapefruit juice. Grapefruit juice is a citrus family fruit and it completely deteriorates the effectiveness of warfarin. Okay, it completely deteriorate the effectiveness of warfarin. Why? Someone can tell me why? Any idea? So first learning for today from today's class is that grapefruits are not grapes. Okay. Yes. Okay. So this is the error. This is the complete drug is error here. Complete drug is error because this is drug without indication. Okay. Drug without indication. Now what about Klexane? Klexane, guys. Yes, Klexane. Anyone? Reduce inflammation and high blood pressure. Klexane. Is it? Dose is zero point 0.6. No, zero point 0.6 is also correct, I believe. Zero point 0.6 is fine. Anticoagulant. What else? What else about Klexane, guys? Do you think it is something drug without indication or something? No. Subcutaneous? No. Root is not SC. SC? Is it? What is the root of Klexane, guys, then? Subcutaneous. It is subcutaneous. I believe it is subcutaneous, right? Yes, it is subcutaneous. So it's correct. What is the problem with Klexane? No. See, the problem with Klexane is Q12 hours. Look at this, guys. You have to be very critical people, my pharmacist people, my uh, upcoming hospital pharmacist and clinical pharmacist. You have to be very critical. This prescription shows you hundreds of the things. You can learn many things from it. Every drug has some kind of error here. You have to learn everything. What, how critical you can analyze a prescription, how critically you can analyze a prescription, you can learn from here. Clexane usually in this indication MI is given peri-procedural. Peri-procedural. This is not the required drug to be given every 12 hours. This is peri-procedural when patient goes for the PTCA just to avoid any further clots formation. We give Clexane only during the procedure that is called as peri-procedural. It is not needed to be continued. You understand that? It is not needed to be continued at all. Okay, it is not needed to be continued at all. Right? What else? I will upload on the YouTube, yes, by night. Okay. What about H2 check D? Yes, guys, H2 check D, your favorite drug. What is the problem with H2 check D? Frequency must be 100 and before food. 100 before food. It must be before food, empty stomach, because it is PPI, before breakfast. Okay. So there are the mistakes. And what are the major mistakes in the entire prescription, guys? In this prescription, any other mistakes you can see in the duration? See, this is a proper mistake for this. Clexane is not continued. Warfarin is not continued. This is not continued. Others can be continued. Okay. This is also the mistake. So guys, what you have learned from this prescription? First of all, see here. See here. Dose related errors. Dose related errors. Okay. MG. Unit related errors. Unit related errors. Right. Then instructions. Instruction related errors. Then what? Again, dose related errors. Frequency related errors. Frequency related errors. Then like missing dose or missing information. Okay. Drug without indication. Okay. Indication without drug. Okay. And then again instruction related error. So you have to, and then days, duration related errors. Duration related errors. You have learned many things from this prescription. And being a pharmacist, you should evaluate everything, you should criticize everything, you should check everything from the first thing to the last thing, from the first thing to the last thing, from the name of the drug to the dose of the drug, unit of the drug, frequency of the drug, instructions to the drug, everything must be checked properly. Then only you can do the proper audit of the prescription. That is the first work of clinical pharmacist. If you want to become the clinical pharmacist, you have to very much critical with the prescription audits. Okay, so I think that's all. These were the drugs. And big blunder was diabetes, and there were some conditions. This was the condition without therapy or treatment. With that, guys, thank you very much. And now I would take your questions. Yes, guys, your questions, please. Yes, guys, your questions, please. Any questions from your side, guys? Yes, any questions, guys? Please ask your questions. You can unmute yourself even, I believe. Yes, you can unmute yourself. And you can speak, you can write the question here. Anything is fine. Do you have any questions, guys? There is no NTG in prescription. It's not needed. NTG is required only when we left anything, any residual block or any residual PTCA or something. Okay, otherwise these are not required. NTG is required in case of stable angina, but not required in case of ACS. Okay, when everything is corrected. Okay, NTG is just the vasodilator and it helps in angina. Okay, so NTG is not mandatory to give everywhere. Okay, that's my answer to you, Look.
Sir, please tell us teratogenicity. Teratogenicity.
Teratogenicity was the thalidomide tragedy. Actually, thalidomide was the drug in late
Sir,
60s. Okay, this is not related to today's thing, but that was related to the old part. The history is about related to the thalidomide. Okay, thalidomide was a drug for, it was actually given painkiller in the painkiller and antipsychotic medication in pregnant women, but that
good
caused
evening, sir.
one by one is will be better, right? So that time this thalidomide drug was given to every pregnant woman. Okay, I mean in multiple conditions, in the nausea, vomiting also it was majorly given for the pain and nausea, vomiting. And then when the results came out, when they delivered the babies came out with the multiple congenital problems. Maybe limbs were not at all developed in those babies. Some other part of the bodies were not developed completely. Some babies born without nose, some babies born without limbs, I mean the hands without without the legs, without the ears. So that was the thalidomide tragedy, and that is teratogenicity. Okay, teratogenicity is like when the medication causes the harm to the fetus. Okay, and there are oncogenicity when the drugs cause the cancer. There are multiple types of drug errors and multiple types of outcome. Teratogenicity, oncogenicity, these are harms. These are coming under the harm. These are coming under the outcomes of medication errors or medication side effects. Okay, now the next person can speak. Could you please explain about transcription errors? See, transcription errors I was talking about. In between also, I was talking about the transcription errors. Transcription means when you are typing,
Good evening.
when you are writing the medications, it goes wrong. Okay, your typing goes wrong with the environment, with the environmental factors, with the listening, with the who is dictating and how you're writing, maybe the pen. There are multiple factors. Okay, in the transcribing transcribing errors. Transcription errors is writing errors. Okay, when there is a permanent harm
Sir,
or
can I speak?
yes, Pritam, please speak. Yes, please speak.
Sir, is polypharmacy a medication error?
Array, my first slide was on that only. Polypharmacy. If the
Yes,
person is
sorry, sir.
taking,
I will be late to from. So,
okay, so when the
sorry, sir.
polypharmacy is the major reason for medication errors. My first slide, my first talk was on that only today. When the person takes more than 5 drugs, there are 80% chances of the medication related errors. when the person takes, the drug interactions, and when the person, anyone takes more than 7 drugs, there are 100% chances of drug related interactions and drug related errors. That was my first sentence when I started. So that is because of the polypharmacy only, and I gave some statistics also on that. Okay. Okay, Puspanjali ji is
Okay,
asking,
thank you, sir.
thank you. When there is a permanent harm, what type of error it is? See, permanent harm error, if you ask me technically, NCCRP, that would be either F, G, H. I mean G or H. Permanent error starts with the G, H, I. Okay, but what type of error? It could be any type of error. If you ask me about, like, it could be transcription error, it could be administrating error, like, or it could be dispensing error also, it could be writing error also, it could be monitoring error also, it could be any type of error. Okay, it is just, the what we say, the severe harm is happening to the patient at any level. It could happen. Okay, maybe when you classify according to NCC MERP, that could be G or H or I, but at the level, type, before, after, or during the prescription, it can happen anytime. Okay, that must reach to the patient. Okay, how to remember the brand names of the drugs and their combinations? That you have to read a lot of things. A lot of things means, when you are a pharmacy student, when you are going to the pharmacy rounds, or when you are a pharmacy student, you are going for the rounds or hospital, or if you are a hospital pharmacist sitting in the hospital, you must, what we used to do when we used to go to rounds, we always have one book in our hand that is called sims. Okay, that used to called as sims. Okay, CIMS. So buy a sims, that is 250 or 260 rupees, maybe now 350 or 400 rupees. Sims has all the latest updated medication names with their descriptions, with their brand names, all the available brand names. You can immediately search the brand name, and that it will tell you all about the drug. Okay, so you have to be constant in the practice. If you want to know about the drug, you have to be constant in the practice. You cannot learn in one day. You have to go through thousands of the prescriptions. Okay, thousands of the prescriptions. If you are a pharmacy student or B pharm student, if you are posted in hospital, you have to go every day, read 10 prescriptions every day, search what drug it is, what are the combinations of the drug, what is the dose of the drug, what are the indications of the drug, what are the side effects of the drug. Read all about. If you cannot remember 10 names, go and check at least 5 prescriptions every day. Then only you will be master of prescriptions and drugs. See, I have done PhD in cardiology, and before that 3 years of the practice. That's how I'm the master of the drugs, because I have spent almost 10 years in the hospital. Every day I read hundreds of the prescriptions. If you want to remember the things, if you want to be a master of the drugs, you have to be in touch with the patients, with the prescriptions every day. Okay, that gives you the glance on the medications. Warfarin and Clexane both are anticoagulant, but both are not required. Therapy duplication, yes, definitely it is. Phocomelia, ADRs are included in medication errors. Yes, ADRs are the part of medication errors. Any mistake which is causing harm to the patient is medication error. Whether it is error, whether it is ADR, mute yourself, please. Whether it is ADR, whether it is side effect, whether it is interaction. Okay, remember, whether it is interaction, whether it is side effect, whether it is adverse event, anything, whichever type of mistake which is causing harm to the patient is called medication error. Okay.
Sir, can I say once again?
Yes, Preetham, please go ahead.
Sir, actually, I am late to join the session, so there is any recording or the slides you can share?
Definitely recordings will be there. It will be available for everyone. Don't worry.
Okay, thank you, sir. And my second question is, sir, what is the way to avoid the medication error for the
What is
patient?
the way to okay, alleviate the medication errors? So this was the method. Go through the prescription thoroughly. Check all the drugs from the doses form. From the doses form, if the doses form is correct. If the drug was supposed to given in as a syrup, why it is given as the tablet? If it was given supposed to given as the capsule, why it is given as the tablet or injection? Okay, then name of the drug, brand name, then dose, then unit. If it is, might we see, as we were talking about thyroxine, thyroxine is always in micrograms, why it was written in milligrams? Okay, then about the frequency, why atorvastatin was given in the morning? It must be given because it is esterase, so it should be given in the night for the better effect. Okay, why pantoprazole was given after the meal? Why thyroxine was given after the meal? So you have to thorough not only with the drug or drug names, but with everything, with the dose, with the frequency, with the units, with the instructions, with everything. Okay, you should know, you should see. I am not telling that I'm also the master, you all are masters, no, but whenever you come through or come across a prescription, read about it. Nowadays everyone has the mobiles in the hands. Just open the Google and search what is this drug, what are the side effects of drug. There is the, in my, when I was in the hospital practices, when I was studying, that time micromedex was very costly. But nowadays micromedex comes in the student package. Okay, and that, I think the monthly charges for micromedex application is just 150 rupees or 130 rupees. Only 130 Indian rupees per month. Micromedex, just download the micromedex, take subscription, online subscription of that, just 130 rupees per month, that's all. Learn everything. There's the best application in the world. Just do it because it is for you. Okay, sir, can you explain difference between disorder and disease? See, disorder and disease are the same thing. Usually there is a very minor difference the people says, but I believe disorder and diseases are the same thing. Okay, any other questions, guys? Carvedilol minimum dose. See, carvedilol comes in 3.25 mg is the minimum dose of carvedilol, 3.25 mg, and then 6.5 mg is the like the normal dose, and highest dose we could give up to 13 mg. ADR and drug interactions are not at all same, Vipin. ADRs are adverse drug reactions. Okay, and drug interactions are when two drugs are having interaction, are not safe, or putting the positive impact on each other. See, drug interactions are not always harmful. Okay, remember that drug interactions are not always harmful. There are synergistic effects also when there are two drugs which can influence each other's effectiveness. That is called synergistic effect. Okay, so these are not always the harmful effects. I mean, we always read that interactions are bad, but sometimes interactions are good also. Synergistic effects. Okay, so drug interactions means when one drug is not given, not supposed to give with another drug. That is drug interaction, because they can either increase or decrease the effect of, like there are two drugs A and B, so A and B are not supposed to give together, because they can either increase the efficacy of each other or maybe decrease the efficacy of each other, and that efficacy could lead to the harm also or the benefit also. So that is called as drug interaction. ADR is adverse drug reaction. So that could happen with one drug also. That is like side effects. ADR in the normal term, side effects. Okay.
Sir, side effect and ADR same.
Is different terms. There are different terms. There is a third more term, ADE, adverse drug events. That is also different. But let's not go to the deeper side of side effects, ADR, and adverse events. Can you give the example of administration error? See, administration error. See, administration error. There is a simple example. Administration error means when you are not looking at the prescription, when you are not matching the drug with the prescription. Okay, and you are not looking at the dose. Maybe let me give you an example. Let's talk about the metoprolol, simple hypertensive medication, beta blocker. Doctor has written metoprolol 25 mg 100. Okay, prescription goes to the pharmacist. Pharmacy, in the pharmacy there is no 25 mg metoprolol available. They have 50 mg, so they given the 50 mg. But when it comes to the administration to the nurse, when the patient is hospitalized, the nurse is just assuming that this is 25, but not matching with the prescription or not looking at the tablet. It is 50 mg. You have to give the half tablet to the patient. That is called administration error. That is called administration error. If the doctor has written, telmisartan, telma or something, and the dispenser, the pharmacist has given Tejal, which is tadalafil, and nurse is not looking at the name. or the patient caregiver is not looking at the name and just giving the tablet whatever is there, not matching that, not looking at that. And sometimes, in as I told with my mom, what we say, define the drugs with the colors, right? मॉर्निंग में लाल वाली टैबलेट लेनी है, इवनिंग में व्हाइट वाली टैबलेट लेनी है, मिडिल में येलो वाली टैबलेट लेनी है. That is also the administration errors, because they don't know, they are not aware of, they're not educated about the drugs, and they cannot remember at that case. Okay, so these are the administration errors. Errors happening by administrative staff. Yes. Errors related to high alert antibiotic administration. Errors for injection. Can you provide examples, sir? Okay, what is that? Let me read. Gayatri. Errors related to high alert antibiotic administration. Errors for injections, injectables. Can you provide? See, first of all, in the injections, there are multiple errors. Okay, when it comes to the injections, it is like mixing, dose calculation errors can happen at the dose calculation, error can happen in the mixing. Okay, because there is no, I mean, there are, we need complete experts to mix the powder with the water of injection, water for injection. Okay, and there are a lot of types of reactions are happening, a lot of types of problems are happening. And when it comes to the injections, people don't know what type of injection it is, whether it is intramuscular, intras, or subcutaneous, or bolus, or there are many types of injectables here. There are many types of injection methods of injection, route of administrations for the injection, either it is IM, subcutaneous, or bolus, or what. Okay, you have to be very much aware, you have to read the prescription, you have to read the the packaging, what kind of it is, what kind of administration instructions are given here. Okay, so that can happen with the injections also. Sir, ranitidine at high storage temperature causes cancer, yes or no? I'm not sure about it. Maybe some experts here can answer that. I'm not aware of the ranitidine at high storage temperature causes cancer or not. I'm not aware of that yet. Please search for the literature about that. I may not be able to answer right now because I've never read about it. Sir, how is decided whether to give injection or infusion for antibiotics? See, that is completely a decision based on the condition of the patient, situation of the patient. Okay, whether the patient is in emergency, severity. Well, there are multiple factors, risk and benefit ratios. How to decide whether the injection is given directly intramuscular, subcutaneous, or infusion, or bolus. There are the different things. See, I'll tell you an example. If the patient comes with hypoglycemic coma, okay, then we don't give when the patient comes with hypoglycemic coma, we cannot give the insulin subcutaneous, we give intrabolus. Okay, we give intrabolus insulin, because we need slow administration of the insulin in such cases, right? So there are multiple examples for multiple conditions, different types of conditions, right?
Sir, my question was like for inject IV route, how to decide whether it's injection or infusion?
It is written.
Like
It is written in the
no
prescription, and it is
bolus.
written on the packaging.
No, sir. Like where some drug they give by bolus and some they give by infusion.
See, dear, that's why I told my first sentence, because of us, it depends completely on the patient's condition, how the patient is presented to the hospital. Okay, as I given you the example of insulin, if the patient comes with the high, uncontrolled diabetes, but conscious to the doctor, they may give subcutaneous. Okay, or IM, whatever is given normally, right? Subcutaneous usually. But when the patient comes with hypoglycemic coma, we cannot give subcutaneous, we give intrabolus, because we need slow administration of the insulin. Similarly, with the antibiotics, in case of sepsis, coma, or any other conditions, we give slow. In that case, we need intrabolus, or infusion, right? And when the patient is normal, conscious, having high grade fever, needs antibiotic, we give subcutaneous or IM. So it is completely based on the patient's condition.
Okay, sir. Thank you.
Thank you very much, guys. Thank you very much, guys. Can you conduct a session on choice of antibiotics? Definitely. Definitely. Thank you. Can you conduct session on what to do after B-Farm? Definitely. Sure. Thank you very much, guys. And I can see my guru here, Dr. Mahadev Bhatt, sir. Sir, namaste. Sir is joining from US. Thank you very much, sir, for joining and encouraging me every time.
Namaskar.
I hope you like the session, sir.
Yeah, I really liked it. You know, when I looked at it this morning, I said, let's find out what drugs he is going to take. और आप तो दिल के आदमी हो, you know. So आपने सब दिल की बात कर ली. I just want to add one thing. You talked about grapefruit.
Yes.
Grapefruit is used very extensively in United States.
Yes.
Okay.
Yeah. Citrus.
And the community pharmacies has to be very, very careful
Yeah.
because grapefruit contains second-degree heart block because it contains quinine.
Absolutely.
And those of you guys in Manipal, you know, there is no liquor policy, you know.
Yes.
Tonic
True.
water also contains quinine, you know.
Yes, sir.
So whenever there is a macrolides, you know, high density antibiotics are taken or antifungals are taken, one has to be very, very careful with the grapefruit
Yes,
because it
absolutely.
is found. And I think the last session which I missed, you know, which I wanted to attend, you know, Ajit, the pharmacy profession is so much interesting, but do you
Absolutely.
love what you do?
Yes.
You know, look at the guys, the way Ajit was going, you know, I can see the excitement on his face when the students started asking question, why not this, why not that? Because he loves pharmacy. Do you love your
Absolutely.
profession? If you
Absolutely.
love it, there is a lot of money to make because this is a complete virgin field. Nobody has told patients. In America, no medication is given to the community pharmacy without the pharmacist look at the actual tablet.
Absolutely.
Whereas in India, everything is strip packing. How do you know they put the right tablets inside?
Absolutely, sir. True.
Like Ajit said, his mom, you know, the color. You have got WhatsApp in India.
Yes.
You can have your own patients and you can take a picture of their tablet and then
Yes.
you can advise them and remind them and
Yes.
make some money.
Yes.
You know, one of these days, I think I send Ajit one picture of my prescription, you know. One of these
Yes.
days we'll talk about it. But, you know, congratulations, Ajit, you did a wonderful job.
Thank you, sir.
And I'm very proud of you. You know, every time I
Thank you very
attend,
much,
you
sir.
know, I learn
Thank you.
something from you. Okay.
Thank you very much, sir. Thank you very much.
Thank you. And
Okay,
everybody,
guys.
namaskaram.
Yes.
Thank you.
Everybody, thank you very much for joining. I could see there were 100 plus people, 100 plus participants, learners.
And Jai
So
Shri
thank you,
Ram.
everyone, and have a good day, sir. Have a good night, people here in India. Thank you very much for joining. Chalo, take care, guys. See you in the next class. And I'll upload and share this class with everyone. Okay, guys, take care. Bye bye.